Similar to bovine, ovine, every species has its own complex, same pathogenesis, stress, viral, or mycoplasma infection, secondary bacterial run. It's the tomato soup pleuritis. Very excited to talk to you about that. My favorites. Okay, so here's the canine complex. Not going to cover this because it's basically copy and paste with different pathogens. Paramyxovirus, so this is canine distemper. This is kind of my mental prototype for paramyxovirus. So multiple cell types infected, including leukocytes. So we're going to get immune suppression with this guy. This is uncommon in the developed world in domestic species. However, we do see it occasionally in wild carnivores. We get a lot of wildlife here. So the host range is pretty broad, and a lot of wildlife species can be affected. Seals, they can get canine distemper. They also have their own distemper, phocine distemper virus. Okay, so here's what that looks like. Encephalitis, pneumonia, primarily cranio-ventral, crusting of the eyes and nose, catarrh to suppurative exudate coming from the nose, ocular area. This is teeth. This is enamel hypoplasia. So when dogs are infected at a young age, while their enamel is still developing on their non-deciduous teeth, you can get infection and death of those brain farting on the name, ameloblasts, the guys that produce the enamel. And then you get these segmental areas where you don't have the enamel form. So that's enamel hypoplasia. And then hard pad disease. Do you guys talk about this in the term section? So crusting of the, especially the foot pads. We see this manifestation quite a bit in wild animals, so like ferrets and stuff. Influenza. Similar to other influenzas, so it follows the rules. This one spreads pretty rapidly among dogs. This wasn't really a big deal until, I don't know, a handful of years ago. I feel like late 2010s. I guess this became a real problem and started generating a lot of publicity. But it spreads basically among dogs. So it's found primarily where large groups of dogs are kept together. So shows, kennels, racetracks, things like that. Primarily self-limiting seasonal disease, but these outbreaks can get severe, especially if there are other pathogens involved. In racing greyhounds, this is kind of a special case. They can develop a severe hemorrhagic pneumonia, often with secondary bacterial infection, but for whatever reason, greyhounds seem to be more susceptible to influenza. Greyhounds, I don't think are dogs. I think they might be aliens. They're like different from dogs in respects. I'm like, are we sure that's even a dog? That's similar to other species, just the dog versions. Bacterial pneumonia, again, copy paste. Hopefully this is getting really, really repetitive. You should look for the underlying cause and the co-infection. So are these animals stressed? Do they have a reason to aspirate? So bacterial pneumonia is not usually a primary thing. It's usually secondary to other things. So go find the other thing. Don't just treat the pneumonia, look for the underlying cause. They're often polymicrobial because they're on this. Everyone's just kind of along for the ride, like, hey, partying along. Oh, me too, me too. I want to come. Most common isolates, these guys that are underlying are probably the top two. But you can get a bunch of stuff. E. coli and other coliforms are more common in cases of aspiration because you're often aspirating gastric content, which has a lot of coliforms. But you do have coliforms in your mouth too. Hate to break it to you. Mouth is just like a slightly bigger butt. From a bacterial standpoint, yes. Okay, so B. bronchoseptica, we've already talked about this other species. This is one that can have a little bit of a virus action to it, so it does suppress local immunity. This can be a primary pathogen in some species. We think about it especially in pneumonia of guinea pigs and turkeys, and then atrophic rhinitis in swine. So those are the big Bordetella. So this guy can be occasionally a primary pathogen. However, spontaneous recovery is really common. It's not super pathogenic on its own. Its primary importance is lowering your respiratory defenses and synergizing with other pathogens to cause a multi-pathogen pneumonia. All right, strep. So E. coli subspecies Zoopidemicus. Most people just call it strep zo. So this can be an opportunistic pneumonia, or there is a special case where you can have outbreaks of very acute, rapidly progressive, fatal hemorrhagic pneumonia in dogs specifically. So if you have an outbreak that seems to be more rapidly fatal than a lot of other respiratory diseases, most respiratory disease you can kind of, sneeze and snuffle along for a while, and it takes a while to progress because you have to go through those stages to develop secondary pneumonia. This is quick. These animals can go quick. So unusually fast and unusually lethal hemorrhagic pneumonia in dogs, think about strep zo. Bacterial exotoxin produced by strep are implicated in these severe lesions. All right, here's a tomato soup. Ooh, right, and here's the sulfur granules. Ooh, right, isn't that pretty? So Actinomyces is kind of this group of gram-positive filamentous bacteria that it covers Actinomyces, Nocardia, Streptomyces, some other things. But these are filamentous higher bacteria. So when I talk about higher bacteria cause higher granulomatous lesions, that's this guy. These are the classic high bacteria. So yeah, these guys, Actinomyces, Nocardia, high bacteria, granulomatous higher bacteria. This is a dog and cat thing, especially outdoor animals, because these are often secondary to some kind of penetrating thoracic wound, like skin to chest. In cats, bite and bite wounds, if they penetrate deeply enough, can do this, and also esophageal bodies that penetrate thoracically, so they'll come out of the esophagus and migrate into the pleural space and lungs. So here's the tomato soup, iothorax. Not really hemorrhagic. It doesn't really look like blood, right? See how cloudy it is? It looks like tomato soup. And it can be chunky. You can have these little granules in it. So these are actually colonies of bacteria because they're filamentous. They kind of like stick together and form like wads. That's what sulfur granules are. It's not really sulfur bacteria. Thank you. And this is kind of a confusing view. So here's lung right here that I'm outlining. Difficult to see. And all this exudate and all this Brondi villus stuff. Do you remember the pleuritis sample from upstairs? Looked like a nasty little brown shag carpet. That's all this fluffy, goopy, villus, tomatoey, delicious stuff. Differential for this is mesothelioma, but mesothelioma will not have a tomato soup exudate. Biogranulomatous also will not have sulfur granules. Okay, mycotic rhinitis. So these are the two classic pathogens we think of. However, you can have occasionally just other saprophytic fungi, especially with immunosuppression. It's most common in dogs. We see Aspergillus, not rhinitis, but pneumonia and aeroseculitis quite a bit in birds, especially water birds, because they're in that damp environment. Captive penguins at zoos get a lot of Aspergillus. It's so wet. So immunosuppression for fumigatus is thought to not be necessary, but definitely helps. If you're immunosuppressed, you're more likely to develop fungal disease. However, fumigatus has some special virulence factors that make it slightly more pathogenic. So this will present as granulomatous lesions and plaques or mats. Importantly, when fungus is exposed to air, it'll form reproductive structures, which are the conidia. So that's all the fluffy stuff. So fungal infection in an air-filled tissue can develop into these conidial, fluffy, red, moldy looking forms. If it's not exposed to air, or if you have a robust inflammatory response, you'll get a more granulomatous lesion. That's this guy. This is a case of Rhinosporidium. Rhino meaning nose. Sporidium fungus is nose fungus. Aptly named. It's a mesomycete, so it's not a true fungus, but don't worry about it. It's a fungus for purposes of this class. These usually present with a unilateral. Oh my God, this lecture is so misspelled. Who wrote this? All right, so here's what that looks like. Yeah.
I'm sorry. Can you describe the difference again? Why does the bottom picture look like firmer than the fluffiness?
So this is Rhinosporidium. This is that unilateral granulomatous nasal polyp.
Okay.
So this is an actual polyp. This is just a mat of polyps.
A mat of fungus. Okay. Thank you.
So this is an Aspergillus thing. This is a Rhinosporidium thing. Okay, here's what that looks like. So here's a cross section of the nasal cavity. Difficult to tell what that's what this is because most of it is destroyed. You see this green fluffy bread mold stuff? That's the conidia, and they're forming in this air-filled space in here. So they're only at the interface between air and fungus. And then all this stuff is our granulomatous, our little separated inflammation. These are usually very, very necrotizing and destructive. So they'll invade the bone, destroy the bone. Here's what that looks like on histo. All these little outlines, those are all fungal hyphae. Here is the air fungal interface, and can't really see any conidia, but this is where they would be. They look like this. They're like little fungus flowers. Very cute. Look like little balls on the end, like those sock pom-pom things. Closer up version of it. Okay, Blastomyces. So now we're into the dimorphic fungi. Rules for these: they are infectious, not contagious. So you get them from the soil. You do not get them from infected creatures or people. The yeast form in tissue is not contagious. These cause granulomatous inflammation, and immunosuppression is not required. So these are like the high virulence fungi that anybody can get. Don't need to be suppressed. Blasto, we don't really see a lot here. So here's kind of the distribution map. We don't see really very much of any of the dimorphic fungi here, which was disappointing to me as a microbiologist. I did a lot of my micro training right here in Texas, where we actually have all three of them, and then plus some. It's disgusting. It's a cesspool down there. Great place to do an infectious disease or pathogens. So Blasto, the keys for Blasto that differentiate it from some of these other guys is the broad-based budding. So their yeast, they reproduce by budding off of each other. This is a broad base, so it's basically the waste between the two that are dividing. This is a narrow base. So Blasto is broad. It looks like peanuts, basically. So big, blue, broad base budding, that's Blasto. Here's what that looks like. So here's a dog lung with diffuse granulomatous pneumonia, where there are really no regional differences. So this is one that could be aerogenous or systemic, disseminated. This, I would guess, is disseminated, but it's hard to tell by looking because everything's involved. And here's what that looks like on, this is a cytology. So pay attention to the size of these guys. These are neutrophils, okay? All these little things. These are Blastomyces. They are big. They are way bigger than a cell. That's also going to help you differentiate them from Histoplasma, which is very small. Big blue. Here's a broad base bud right here. See the peanut shape? Broad base right there. Histoplasma. So this we also don't have here. This is more of a Midwest. The Midwest is like the trifecta minus Coccidiodes. Coccidiodes. So again, dogs and cats primarily. This was transmitted from cat feces. So this is a soil organism. Again, granulomatous pneumonia. Lymphadenitis is also common in dissemination. A high dose of infectious organisms sort of depressed. Histo is one that likes the intestine. You talk about histoplasma. Maybe not. You don't see it here, so it's kind of off our radar, but very common in other areas and very common. So these guys are small. They're intrahistoacidic. So multiple histoplasma organisms will fit inside a macrophage versus Blasto, which is like as big as or bigger than a macrophage. So here's the lesions. We have another diffuse. Actually, this is more multifocal to coalescing granulomatous pneumonia. Here it's pretty diffuse. This, believe it or not, is a lymph node that's just been totally effaced by granulomatous inflammation. And this guy is a narrow base bud. So histoplasma, tiny. There's a bunch of them inside a monocyte macrophage. Blastomyces, again, Here are leukocytes. Here's a neutrophil. Macrophage. This might be a macrophage, and here's a broad-based budding blasto. So it's one blasto is like the size of macrophage, at least. It's very big. Histo, very small. Narrow budding for histo, broad budding blasto. Coccidiodes immitis. This is also known as valley fever because it primarily comes from this Central Valley, California, right here, where I lived for a year and thankfully did not catch it. I also worked in a micro lab in Texas where I was accidentally exposed to Coccidiodes on that culture plate. So that was fun. It's kind of like a microbiology rite of passage to get exposed to this bug accidentally in the lab. I found out. Cannot recommend. It's very scary. Everyone costume. Anyway, okay. So this comes from the Central Valley primarily. It does kind of eke into other parts of the Southwest, but it's common in humans in this Central Valley as well. So there's a couple different presentations. There's a respiratory presentation. There's a cutaneous presentation. In cats, they like to present with the cutaneous form. That looks like a human. It's a big granulomatous. Cutis. Late in the disease, this can go to the bones. It's osteomyelitis, with that plainness, and it also lights the eyes. So it goes everywhere. Pathogenesis is pretty similar for all these guys. They just have different regions of the US that they come from. Presentation similar, but they like to go to different organs when they just think. So blasto really likes the eyeball, for example. Histo really likes the tract. Coccidioides likes the skin, especially in cats. So this guy, compared to a histo or a blasto, this is like the size of the sun compared to a blasto. These are huge. They're like 300 to 500, up to 200. I swear I've seen ones bigger than that. They're massive. So like this is a neutrophil right here. These tiny little things are neutrophils. And this is a Coccidioides, spherial. And all the little things inside of it are spores. So this whole big thing with the really thick capsule is spherial. This is a very, very characteristic appearance, and it's huge. Paragranulomatous or caseous pneumonia. Here's what that looks like. So this is multifocal. We've got lesions all over of varying shapes and sizes, but it's overall granulomatous to pyogranulomatous. All right, so BOAS. So we had one of these upstairs. It's pretty good. So BOAS, I like to separate into the primary lesions, which are the congenital. These are the congenital lesions. And then the secondary lesions, which are what happens when you're dealing with obstruction from your congenital lesions. So secondary lesions are a consequence of the primary lesions and of dyspnea primarily. So the primary lesions are stenotic nares, so normal nose holes right here. This pug does not even have a hole. It's like barely a slit. This animal cannot breathe. Redundant soft palate, so elongated soft palate because we bred a short nose and we have not bred a shorter soft palate, so it dangles into the airway and causes obstruction. And then hypoplastic trachea. Remember, hypo means less than, and plastic meaning plasia or growth. So not enough growth of the trachea. The tracheal lumen is too small in diameter. And often when you look at these on histo, there's actually overlapping of the cartilage rings. So you have failure of formation of that dorsal ligament. And instead of having this much space, you're overlapping and you have this much space. So your trachea is too small, your nose holes are too small, and you have a palate hanging in your way. You can't breathe. Therefore, you develop secondary lesion. So severe dyspnea causes laryngeal edema just from the extra work of breathing. These are the laryngeal saccules here. So the vocal folds are right here, and there should be that little pocket that goes inward. They should be inverted. You should not see them. With laryngeal edema and severe dyspnea, they will evert into the larynx and cause more obstruction. Pulmonary edema, again, from the increased work of breathing and severe dyspnea. So these all kind of like feed back on themselves and cause more obstruction and make everything worse. And die or aspirate and then die. We see this a lot. This is a common cause of death in these animals on the floor. Meaning chronic bronchitis. I'm not going to talk about this. The information's there on the slide. And this PowerPoint is quite as big as small animal, but there are chickens on here. So idiopathic fibrosis. It's not just West Highland whites, it's also cats. There's an idiopathic fibrosis syndrome in canines, also humans. Human IPF is a big important disease. We don't know the cause of this, obviously, because it's idiopathic, but the presentation is just slowly progressive chronic fibrosis of your alveolar septum. So you're just getting progressive respiratory. Potential model for the human disease. Pulmonary osseous metaplasia. So it's not really a lesion, it's an incidental finding. This is primarily in dogs, cats, but it's usually middle-aged to older animals. This is a metaplastic, not neoplastic change. Do you remember metaplasia? There's one tissue type to another tissue type. So we're going lung to bone. This one. They're very tiny. They cause no problem at all. So you're see these little tiny white spots, and they're bone, so they're hard. Hard your forehead, it's bone. They can be anywhere in the lung. They're usually small. It's usually multiples, but not a ton, like 10 to 20 per lung. On radiology, they're going to call these osteomas. But an osteoma, if you break the word down, oma is a benign tumor. Osteo is bone. This is not a tumor. It's metaplasia. It's not neoplasia. Make sense? When you get to radiology, you'd be like, excuse me, your terminology is incorrect. I'm treating sense, so you can leave that last part off. Okay, so incidental renals next quarter, right? Yeah. So uremia is end stage. When you're in end stage renal failure, uremic toxins build up in your blood, and they cause all these secondary systemic lesions. One of which is uremic pneumonopathy. Remember, apathy means something wrong with. It's not very specific. And why do they call it pneumonopathy? Because we know what's wrong with it. It shouldn't be an apathy. It should be an osis, right? And because pneumonosis. Just thinking out loud. Okay, so it's not an inflammatory lesion. It's actually mineralization of your pulmonary interstitium. So you see all this kind of like bright blue, chunky, sort of gritty looking stuff. So this is all mineral. And here we've actually stained it with the von Casa, which picks up mineral, and all the little black dots are positive for mineral. So is this dystrophic, metastatic? Primary necrosis of the lung leading to mineralization, or do we have a systemic mineral imbalance because our kidneys are systemic? Metastatic mineralization. So grossly, often none. If you do see something, you'll see pulmonary edema, because this is similar to like an interstitial pneumonia, where you're attacking the interstitium and all that's there is capillaries, pneumocytes, right? So you're getting lots of fluid exuding into your airspace. So edema can be pretty severe. Look for other lesions of uremia to confirm. This is one you're not going to see grossly. So look at the kidneys. What do the kidneys look like? Do you have mineralization of the gastric mucosa? It's another place that likes to mineralize. The parietal pleura, especially the intercostal spaces, so the pleura between the ribs, you'll see these little white streaks of mineralization. And then oral or tongue ulcers. That's due to vasculitis.